Welcome. We're going to do 45 minutes of talking about the bow. I assume everybody here has seen our YouTube video that explains the concept behind the bow. So I'm going to go a little bit of history of how the bow was created, and then I will show you a few early cases that we have. And if we have time, we can either address the questions or work with the bow physically if anybody wants to go over the bow, or we can see some long-term cases that other practitioners have been successful with on the bow. The bow was designed by me and my son to address his issues because there wasn't a mask that had bimaxillary effect. All the face masks in the market had they would cold on the face, on the jaws. So there was a vector of force working against what we wanted. So we designed the bow to have an anchor at the chest and at the forehead so that the jaws are free to advance. We created the bow to attach to an orthodontic device, ideally an orthopedic expander. It can be a fixed expander. It can be a removable. We use it mostly with stage 1. So let's go over the cases that I have. And let's start today with a little bit of a question. Let me put it here, share my screen. Okay, so this is the bow. It's a fantastic device, but we really have to understand the prescription and the protocols where the bow is being used. I saw this case, and I don't know if you guys see my full screen. Okay. So this case we were looking at, this is one of our master forwardonists, and this is a case that came to her office on a transfer. And this is a typical case of this girl is 11 years old, and it's the patient that will tell you that they will do whatever it takes. Is this the patient that we want to use a bow in? And what are the side effects of the bow? So we have to be very careful so that we drive treatment as forwardonists, as orthodontists, as pediatric dentists. We need to drive our treatment. We need to drive our own patients and funnel them to a path where they will be successful. Our responsibility as I don't know if everybody read the letter that I wrote on our study group, but our responsibility as clinicians is to set the expectations of our patients so that they can have their genetic potential. They can express their genetic potential. So every patient has a genetic potential. There's an envelope, and they can be anywhere in that envelope. So our job as a clinician is to take them to as far forward in that envelope, closer to what their genetic potential is. I do believe from all the research and from the studies that I've done in evolutionary biology that we all have the availability of being able to have nice forward developed jaws with wide airways and to use them potentially for 100 years, and we can improve our health and our looks together. And we can sleep better, we can breathe better, we can function in every way better if we have that development. So this girl comes to an office and she says, the mom says, and the girl says, I will do whatever it takes. If I have to wear that monster over there, I will do it. And it's our job to know that we need to give them things that have the potential and what we call the effort that they're going to put in, it's going to pay off. The dividends they're going to get for their effort are there. So if we're going to have a treatment that's going to be a huge effort for them, we got to make sure that the result matches that effort. 11-year-old girl going to have enough growth potential to really, really create a change that's meaningful, even if she wears the bow 24 hours a day? And the bow is not supposed to be worn 24 hours a day. It's a very powerful device, and it has a huge vertical component. So, in my opinion, I, as a clinician, would not give this girl a bow. When we look at our numbers, we look at our indicator lines, we overlap our Bolton template over the face, we know that there's a lot of vertical growth. And whatever we do in this patient is definitely going to worsen the case. Do we have time? Do we have growth? Do we have potential to make it better? Some cases we do. At 11 years old in a female, I am a little bit skeptical. So we gotta give our patients what we know that they're gonna have to succeed. I'm not saying you should use or not use on this girl, but I'm telling you that you should set your goals very realistic. One of our masters was telling in our group saying that we under promise and over deliver. We have to under promise, and then when we deliver, we are delivering more than what was promised. So this girl deserves for us to tell her what it is that she needs to do and what result we're going to create for her. Okay, so this is her dentition. She's a transfer case. There is a lot of angulations and a lot of compensations that this case has. So this is a very, very complicated case that I personally would treat. I would treat with expansion. I would treat with preparing this case, with creating the angulations that are ideal for the size of her bones. And I would give her the ability to try as much as she can. But I know that my limitations in this case are the age, what she's already been through, the emotional part of an 11-year-old girl that's closer to getting into the teen years. So there's a lot of things that are red flags in this case. So I personally would not start this case with a bow. I would prepare this case for maxillofacial surgery. I would help this patient have the best possible success with a very knowledgeable doctor and a very knowledgeable surgeon that I would guide to give this patient what I think this patient needs. So it doesn't mean that you're going to leave this patient out to dry, but you are going to give them what you know you can deliver. And it takes a lot of guts to say to a patient, no. We are trained to try to help everyone. And one of the things I've learned from some of my colleagues is it's not our job to save everyone. I wish we could save everyone, but we can't. So we need to choose our battles and choose our patients. And sometimes the more respectful thing for a patient and for us is to say no. How do I know this? So this is my own son. A lot of you guys have seen him. This was part of a journey that we went through. And this was a kid that would do whatever we asked him to do. He wanted to improve. He wanted to cooperate. And he had a family that was going to support him on anything, whether it be traveling, whether it be getting this facial mask that wasn't in the market or creating their own. And he was willing to wear this 24/7 if it was necessary. So what happened with this kid? There was a point where what we were doing was not working. He kept telling me that his face was pushed back with everything that we were doing. He was feeling that there was a vector of force going back. So we started inventing. My son has a very good engineering brain. And so we started playing with the 3D printers and trying to come up with something that he would not feel that was pushing back as the vectors of force that we needed were acting on his expanders. And it was working. We created this mask that I absolutely loved. But what happened, he wore it very well and his jaw started moving forward. We were very excited until one day he came up to me. He was, I think, 12 at the time. And he said, "Mom, this is great. It works for me, but please don't ever give it to another child. I'm a ninja. I can handle it. And he took my finger and put it in his forehead, and he had created on the bone in his forehead, he had created a little step in the bone. So as we were moving the jaws forward, the force was really levering on his forehead. So we tried every combination we could, and we printed, tens, if not hundreds of devices, until one day he said, "Mom, this is not working." I said, "Well, if you're so smart, what would you do?" And he took a napkin and drew this for me. He was 14 at the time, and he says, "I need the forces to be divided between my forehead and my chest. Nothing levering. So you need a second force to anchor." And he created this drawing, which I took to the Biomechanics University in Valencia, and we started building the bow. I said, "Well, how are you going to move your head if you have an anchor in your chest?" And he said, "Well, you figure out, Mom, like a knee or something that rotates or something, engineers can come up with that." So we ended up, after trial and error for several years, we ended up with this fantastic device that actually swivels, but it also goes in and out, up and down, in and out, and sideways. So it's an appliance that leaves a lot of freedom for the patient. It is very powerful because there's nothing anchoring against it in both jaws. So this is the first, we coined the phrase bimaxillary protraction device. There's no other bimaxillary protraction device in the market. And this is the long story summarized of where he went, and he's 25 now. So we've had the bow for about 12 years. This was our first course that we did. This was one of our patient zeros. I was teaching at the University of Valencia back then, and we had an incredible result with patients that most of them were class 3, because those are the patients that are going to be willing to do what it takes. But in only a few weeks, we started seeing this softening of the features, these lips appearing for patients. So it was very, very exciting to be part of this paradigm shift where we started bringing jaws forward together. This was part of our first seminars that we were working with kids, and we were showing that the vectors of force on the bow are different than what we have in orthodontics, orthopedics. In orthopedics, and a lot of us still use the mask because it's what's available, but the vector is always down, because how do we correct the malocclusion? Is by coming down and back. And we have a differential of the jaws where the upper jaw comes down and the lower jaw goes back as they come down, and we increase vertical growth, creating more of a gummy smile, more vertical development on our patients. So we were trying to change that. You guys are familiar with our stage 1. I still feel this is the best appliance to work with the bow. We do have adults that are being treated that use the bow, but this for me is the best. This is an early appliance that we were creating. It's not a great appliance. It has some mistakes, and the shelves are critical, especially if we're going to control vertical growth on the bow. The forces that we use on the bow are light. Usually we go to somewhere like 20 pounds on each side. I'm sorry, 200 grams. 200 grams on each side. And that is a lot of force. And we have the patients vary the force so that they're comfortable, and we help them keep the vector of force horizontal to Frankfurt. So we want them to try to use this appliance, keeping the elastics in a more horizontal. If we look at the protocols of using face masks, the vector of force is always down, about 20 degrees down. We like to have a horizontal, completely horizontal to the mandibular plane, to Frankfurt. So this is what we do with our patients. This was our patient 0, the youngest patient we treated, or that I treated at the time. This was a little 2-year-old. And, I apologize because I'm going to show a lot of cases that are, do you need this?
Yes, we are on live in Instagram too.
Ah, okay. Well, then I need a clock. So I need to know how fast to, can I have a clock? Because I can't see it in my computer. Okay, so this baby was having problems eating, and class 3 couldn't chew, and this patient again would do what it takes. I didn't know what I know today, but we were able to convert this boy into a class 2 boy, because we were able to get in early, get that mass in, and you can see that even the malar bones, you could see that we developed all the way up, because we started very early. This was a little baby that was already considered class 3 surgical case. Even by the time he was 2, he was already starting to hear, the mom was starting to hear that this little kid would need surgery. So we were very thoughtful about working with this kid. We started using our stage 1. Back then, I would make all my devices, and I really didn't know what I was doing, but I knew that I could give the patients a vector of force that could help bring forward the whole middle third of the face. This boy had a little bit of relapse. His function was his nasal function was a problem. He was actually syndromic, and this is by the time he was 5, he was having a little bit of relapse. So we created another device for the patient, and we kept treating him, because we didn't know what we know today. We had to go through several rounds of treatment, but he was a very, very good user of the bow. He was always sleeping with it, and he really had a very nice result, where he was able to move on and have a very nice developed maxilla. And he had a lot of issues, but we got all the teeth in. Here you can see that he had a blocked tooth on the upper left. So we created a stage 1 with a screw to distalize the molar, and we created space for the bicuspids. So this was a very interesting case where we had a patient that helped us understand the potential of the bow and the stage 1 combined. Used it for a long time, and was a very successful case.
A ver, muévete hacia arriba. Hacia abajo. Muy bien. Hacia arriba. Hacia los lados. Muy bien. Muy bien. Pero muy bien. ¿Estás cómoda? Sí. ¿Sonríe? Gracias.
Okay, so the bow is a tool for an orthodontist that knows what they're doing. We've used reverse pull headgears for over 50 years. There's a lot in the literature. So it is a tool for an orthodontist that is comfortable using reverse pull headgear. It's my recommendation to start with the class 3s, because those are the patients that will do whatever it takes, or with the patients that really we feel we can make a difference, that are young enough. This girl was a 5-year-old, and she was an adopted girl, adopted by a pediatric dentist brother, and she had a class 3 malocclusion. So she was willing to do what it takes at 5 years old. So this kid needs to work with GoPex, needs to work with posture, needs to work with chewing. The bow comes in a package with chewies and different devices, but you have to understand vertical growth, and you have to understand how to control the vertical growth, vertical development side effects of the bow. The bow absolutely has side effects. So we have to use it being mindful, being knowledgeable, and using it as a tool in the toolbox of an orthodontist, orthopedist, or pediatric dentist that understands vertical growth, that understands physics, vectors of force, and understands the psychology of the families and the patients that are going to be using this. So it is, I call all my devices are like riding a bicycle. You start using it, and as you use them, you develop your own techniques. I know the System Vivos uses a lot of bows. They use it on adults with their device, and they actually teaching me a lot because I will not use this in an adult. It's not part of what I recommend. I focus this as a growth device, but I know that adults use it successfully, and I have my WhatsApp full of cases that have improved through using the bows. So this is a tool that you need to learn to use on your own. I'm going to run through these figures very quickly because the bow is not something that we just created out of space. We really did a lot of science, a lot of research, and it took us 2 years to get it into the market because the Instituto de Biomecánica de Valencia, they ran a sample based on, there were 1,200 children, and they had these heads designed, and these heads were used for, in Germany, for designing cars. So they had heads of different ages. So we created our 3 sizes based on the sizes of the sample of this algorithm that the university and the Biomechanics Institute helped us. And so the bow is not perfect for every patient, and we have to, as clinicians, figure out how to get it more comfortable to our patients, but it's based on the averages and the shapes and the sexes and the sizes of our patients. So we have to sometimes decide what patient is using it, how they're going to use it, what the shape of their forehead is. And we have those 3 sizes, of which we have available only 2 of them, that we have the small and the large. And sometimes we have the parents figure out how to adjust the medium or the small size to a younger kid using a cloth, using a foam. So we have the parent being the parents have to be involved, or the adults are using it in getting this to be more comfortable. We do have patients that tend to put their head forward, so we have to work with posturology to help them do GoPex and to hold their shape and their posture correctly when they are standing up or when they're sleeping. So this is something that was designed and developed through the different algorithms of shapes of foreheads, so that these are the most comfortable that we could create for our patients. So we have our 3 sizes, of which we really only have the small and large. So we don't have the really tiny one, the extra small, but we decided that these 2 were enough for the time being. Eventually, as this device catches on, we might do the other 2 sizes, the extra small and the medium. But right now, we've had good results with what we've done. We also use those heads to create the curve in which the bow works. So it always leaves free the jaws. And it's interesting because we've had clinicians that give the bow to patients that have used a facial mask, a petite or a delaire. And when they first look at it, they say, oh no, this is gigantic, I don't want it. But a patient that has already used something that anchors in the face, and anybody here that has treated patients that have anchored in the face, we know that we create areas of roughness, and the irritation of these devices in the face are uncomfortable. This device doesn't leave the face free. So the patients that have worn, let's say, a petite mask, when we change them to this, they go like, wait, this is way, way, way more comfortable than what I was wearing before. And they're able to move through that curve. The straps on the bow are suggestions. We never really designed the straps perfectly because we're still this is a group that is always growing, always developing. So we created some straps that work for us. But we've had doctors, we have a doctor in New Zealand that created his own straps. We have moms that sometimes sew their own straps, but this is what works for us right now. So this is what's available. Of course, we always measure our expansion, and we always recommend using the bow once we've achieved a certain expansion. If we're doing 38 or we're doing 40, whatever we're doing, we like to start the bow. In our protocols, the bow goes in when we are ready to wear it as much as possible. When we're ready to wear it as much as possible, we go for it. We do have some of our patients that have vertical growth. We have combined it in the past with extraocular arch that we bend up, sort of like a hypo headgear. And we have done this in some patients where we really, really want to control vertical. So again, you have to babysit these patients, understand your mechanics, watch them all the time, and create a system. Here we took the front piece and we put regular cervical headgear. We bent it up, and we had the patient use this in addition to the bow to maintain and get as much horizontal growth as possible. So it's not an easy device, but it is a tool that can allow you to do a lot more with your patients in the forward development of the jaws. These are instructions that come in on the bow. For me, they're extremely clear. They have drawings, and we understand how to put it in, out. There are certain things that I see that we tend to make mistakes with. One of the parts, I don't know if you guys are seeing my video, but the T is bent this way. This T here in this bow is placed incorrectly. And this is the way my staff gave it to me, and it's placed incorrectly because the T has to be out so that we have the different attachments for the elastic. So we can make it more or less active. We can put more force on it. So we want to we give our kits coming with sample elastics, so you can vary the force on the elastics. We have 8 ounces, we have 12 ounces, so you can do a figure 8 and adjust it, and the patient themselves they can make it less or more stretchy on it. So you're keeping it in less than 200 grams. The less grams, the better, because it's a very, very powerful device. So you let the patients kind of figure out how much to wear it, and you have to have a very tight, if you're using a removable stage 1, you have to have something very tight, or you can have something fixed. We have patients who now use the mini implants. I don't know if you guys are familiar with Dr. Leclerc treatment with the bowler hooks. Bowler hooks are plates that are put in the bone. So this can be used very successful. We've had patients, and we had doctors that do a lot of MARPI. Dr. I think Lipkin, he was telling me that he recommends the bow for any patient, adult patient that has MARPI with fixed anchors in the bone. So this is a very good device for patients that are willing to go through that. With that, this is mainly what we are talking about. Patients send me pictures all the time of them sleeping. The vector is not always straight. Sometimes it tends to go down a little bit, but it's in the general area of straight up. So I get pictures all the time from parents. I was telling you that some of these are from our parents. These are from Korea, South Korea, and we have doctors over there. They have a lot of class 3 patients, and they understand class 3 treatment really well. So some of the parents create their own straps. If you look at the chest piece of the bow, it has different perforations, so that if you decide to put some straps up here to keep the piece from moving up or down, Usually it's up that it tends to move, as you can see from the arrows here, it tends to move up a little bit. So keeping it down makes it more comfortable for the patients. I feel that this device doesn't need to be tight. It can actually be pretty free with the light forces of the elastic. So I don't find that straps are necessary in the patients that I've treated clinically. But can I still have my clock? Thank you. So we have about 15 more minutes? 10 minutes? Okay. So let me show you just a few cases. These are very early cases, but I'm very proud of these cases because I feel that this is the correct patients to start. Young patients with crossbites that, are willing to do what it takes. The parents know that this is a problem. So we have this type of patient that needs arch development on the top and slight compensation on the lower. These are my designs, my early designs for our patients. We look at where the teeth are coming and we need space. So we want to bring that whole maxilla forward. Here you can see the turbinates in the nose, which is what I look at today. We have our nasometer, so we can actually tell the patient and the ENT that this is a problem. So when you're going to use the bow, you want to maximize what you do as a clinician to respect the effort that the patient is going to put in. So if you see a nose like the one we see here, you got to take care of that. And this is also a way to guide your patient to tell you this is something that's for them or not. This is not an expensive treatment. There's a lot of responsibility and you have to charge for your knowledge and for your service. It's a huge service for patients. So you send them to the ENT and have that taken care of before you start. This patient was one of our early patients, very flat cheek line. We used to do a lot of our angles that we measured. We see that there's adenoids, there's turbinates, there's a lot of issues with the low tongue. And I'm not going to go through a lot of details, but we start treating these patients early and we start treating them slowly. We also do a lot of intrusion because every case that we treat with a bow is going to have a vertical component. So these are our springs that helps us control vertical and intrude the permanent teeth. It's great when we have deciduous teeth because it helps us control that vertical. And last but not least, I'm not going to show you more cases. This is going to be my only case that I'm going to show. We might do another session with Bo because I had about 20 cases that I wanted to show, but I'd rather show you what's possible and then we can continue to do more workshops and see some of your cases. But it's very important for me to control vertical, to have a patient that is going to do their job and they are going to commit to being compliant. And they have to know what compliance means. They can't come in and say, I'm going to do whatever it takes. I'll wear it 50 hours a day. Whatever you tell me, I will do. No, they go to GoPex. They prove to us that they can do what it takes. Now we have the GoPex app, which is great. So this patient was willing to do it. We can see, I don't know if we have audio, but we can see that he had a lot of dysfunction, a lot of airway issues. And these patients that have crossbites early, they are going to have dysfunction by definition. So we want them working. You can see this kid really was having a very hard time pausing. And the magic in GoPex is on the pause. And these kids don't know how to pause. So we have to work with them because they have a lot of dysfunction. So this kid worked very well with us. Oh, sorry. We can see here that there's a lot of posture problems with the patient. This is the wrong chair. So this was a patient that really had a long way to give us a perfect GoPex, but they were willing to work with us. They were willing to understand this. So here we're telling them the chair is too high. We don't have a good angle. It's too soft. He's rotated. The neck is forward. Obviously, these patients are going to wear the bow are the patients that already have dysfunction. So we have to work with them. We have to show them exactly what we need. And if we give them very specific, clear instructions that are easy to follow, that are not going to be a huge problem, they're going to comply. They're going to do what we ask them to do. And with the app, we can follow them and we can make sure that they're doing every step of the way what's best for them. And then after they've proven themselves, we can give them the bow. See how this kid is really very quickly turning into a different kid. And for me, the hip is very important because once you get the hip right, then the neck starts being straight. And the bow will have a tendency to move the neck forward because of the force. And a lot of these patients think the more the better, so they add more force as soon as they can. And they say, well, this doesn't hurt, so I want more force. And the neck comes forward. So we gotta work with Gopex with every patient that's wearing the bow. It's 7 minutes a day, but it is critical that we follow these patients and we make sure that they're committed. And then we can be committed to them. Within a few weeks, they do turn into people that are willing and they're understanding where we're going, what direction we're going. So this was it was a lovely case. It corrected very well. It was a more horizontal grower, but you can see, I'm gonna stop right here, but you can see that we are on the way of creating the possibility for this patient to continue to grow at 11 years old, being male. He has a lot of growth left in his lower jaw, so we can still decompensate the angulation in his lower teeth, leave him with a nice open bite, and continue with Gopex and an op blocker, which we didn't have at the time, but we now have, so the tongue can help us continue and maintaining nasal breathing at rest. This patient really benefited of this device. And I would suggest if anybody has questions or you want to test out the bow, to really do it in a horizontal crossbite patient that is understanding and it's on board with the family and with the child himself or herself, knowing that what we expect from them. And with this, I'm going to stop.
Okay, questions?
Does anybody have questions? I see there's a very nice group of people here. So I'm willing to stay as long as you guys want to ask questions or continue.
Okay, thank you so much, Dr. Kahn. We have one question in our chat. Hey, Dr. Barragan asks, until what age people can use the combo?
Look, this is not a cooking recipe. This is a tool that the clinician is going to choose how they're going to incorporate it into their treatment. I personally don't believe in treating adults with a bow. I just don't. That doesn't mean that you don't treat adults. It means in my hands, I'm not comfortable because I am a user of orthodontic surgery. My daughter went through orthodontic surgery. I had a centimeter of advancement by maxillary advancement. My daughter had almost 2 centimeters. So for me, the possibility of orthodontic surgery is a way where I feel I can serve my patients, and I treat everyone in my practice, and I teach my students to treat everybody like I treated my own son, very young, with this device. My daughter, I did not treat with this device. She went to orthodontic surgery, and I didn't use the device myself. So for me, the ethical way to treat patients is as we treat our own family. That doesn't mean that this cannot be used with adults. As I said, the MARPI protocols are improving a lot, and a lot of adults are starting to wear this, and we know because we provide the bows to a lot of groups that are using them successfully. Okay, I don't think there's a lot of questions. When there's no questions, you either understood everything or you understood nothing. So it's really this device really is very close to my heart, literally. And it was created by my son because he really felt that what we were giving him wasn't helping. So for me, it's something that came from the user, not from the provider. And I think I can make myself available to comment on cases. We can do it privately, we can do it in our forums. But I do think there's a lot of people that are using this and they're finding out what the limitations are for it. For me, this is a device that I've been preoccupied with other devices, with children and with things that are simple. This is a more complex device, but I am looking forward to returning back to improving it and to working with teams that can make this available to more patients that want to use it, that don't have orthodontic surgery available, or that can be improved in their growth. The one thing that I've always underlined is that this device has a huge vertical component. It's not for people that don't understand or don't value vertical growth. I do find that orthodontic programs and orthodontic techniques today don't really focus on controlling vertical growth. So I would say this is not for any user that doesn't understand vertical growth, because I've used it a lot. I've had this for about 12 years now. So I've used it in a lot of patients, and not every patient has been successful. And I've had side effects that I needed to backtrack. I am a huge fanatic of vertical growth. Since I went to school, I went to University of Pacific, where one of my first mentors, who actually, I don't think he's around, Dr. Lieberman, he came in and he said, one of the first days I was in ortho school, he said, if you ever run into trouble, the answer will always be vertical. And that stayed with me through my 30-year career in orthodontics. If you have a problem, the answer is always vertical. So if you're going to use it, be mindful. This has a huge vertical component. So I've used cervical headgear with it. I drilled holes into this plastic. I glued things into it to have the patient wear elastics to control vertical. I've intruded 6-year-old molars with it. There's a lot of creativity, and this really tests the biomechanics background. I was fortunate enough to be in the class with Dr. Burstone for a whole year. Every week I was studying with Charles Burstone. So I had a very strong background in biomechanics and physics. And I don't see that the young people, the new generations, have that strong component in understanding forces and physics. So if you're going to use that, be mindful of that vertical component. I don't want to see vertical faces. I don't want to see Frankensteins coming in and saying, we fixed the teeth, look how beautiful the smile is, and I can see nothing but the long face. So it's a tool. Use it mindful. My team can have my email and WhatsApp available to you guys for questions. And I would love for everybody to teach me more about the potential of this incredible biomechanics device.